Clinically borderline resectable pancreatic ductal adenocarcinoma. It is important to emphasize again the limitation of the EGCC staging system when it comes to the anatomical resectability. Like T1, T3 tumors based on the size, whereas T4 that can be size, any size, but it involves the peripancreatic visceral artery or arteries. The degree of involvement is not specified in AGCC. Like supramesenteric vein, portal vein involvement is not included within the T stage. It is only the arterial involvement that has been included, but not the venous. So therefore, from an anatomical staging standpoint, T4 that can range from borderline resectable to locally advanced cancer based on the consensus criteria. It is implicit that patient conditional factors and biological factors, they are unaccounted within the TNM staging system. So as described in the section on assessment of the clinical resectability earlier in this chapter, patients can be deemed borderline resectable when it is called as borderline resectable based on the presence of conditional factors like patient's age more than 80, ECOG performance status more than equal to 2, presence of potentially correctable, optimizable medical comorbidities or nutritional status. These are all conditional factors. And biological factors like CA99 more than 500 unit per ml, regional improvements. In addition to more often discussed anatomical consideration, advanced age is another otherwise conditionally appropriate patients should not serve as a contraindication to pancreatectomy. Elderly patients who receive multimodal therapy can achieve reasonable long-term survival. So there are currently no prospective randomized data clearly define the role of neoadjuvant treatment sequencing in patients with anatomically resectable tumor but conditionally biological borderline tumor. So when neoadjuvant therapy in a clinically resectable, more philosophically driven in the past, there is consensus favoring neoadjuvant approach in borderline resectable patients. Results of recently published prospective RCTs, prospective trials, single arm, anatomically borderline resectable disease land more definitive support to neoadjuvant treatment. Anatomically borderline resectable disease land more definitive supportive neoadjuvant treatment approach. So resectable pancreatic ductal adenocarcinoma questionable regarding the optimal chemotherapy regimens and duration have not been definitively answered, and the role of radiotherapy is unclear. So basic management considerations at presentation. The initial evaluation of the patient with presumed pancreatic ductal adenocarcinoma will be the same whether the patient ultimately is demonstrated to have resectable, borderline resectable, or locally advanced disease. These components of workup and management have been addressed previously in the chapter, and patients will require histological confirmation. So for giving anesthesia, patient require histological confirmation of the pancreatic ductal neoadjuvant chemotherapy is planned. Then biliary drainage, gastric, duodenal obstruction, that should also be addressed through endoscopic or interventional radiology approach. Surgical aortic bypass can also be utilized to achieve gastric outflow obstruction if endoscopic approach failed, not feasible. And these interventions will be concurrent with other assessments and required interventions, including nutritional optimization, correction of dehydration, electrolyte abnormalities, pain management, attention to anxiety, nausea, depression, and exocrine insufficiency due to obstruction of the main pancreatic duct require oral enzyme supplements. Exocrine insufficiency, they require oral enzyme supplements, and the supporting care consideration have been summarized by Wang and William and colleague. And it is important to emphasize again the multimodality team with focused management expertise for gastrointestinal malignancy of the upper abdomen achieve the best results and include expertise in the pathology, chemotherapeutics, radiotherapeutics, and surgical management, intervention, radiology, and diagnostic therapy. Now, recent trials in anatomically borderline resectable. So, Zhang and colleague recently published the phase 2-3 randomized RTC Benefit of neoadjuvant chemoradiation therapy compared to upfront resection followed by adjuvant chemoradiotherapy in patients with borderline resectable pancreatic ductal adenocarcinoma. So this trial (110 patients with a primary endpoint of 2-year OS, secondary endpoint of R0 resection and 1-year OS. Chemotherapy neoadjuvant adjuvant. Total dose of RT is 54, 45 gray in 25 fraction followed by 9 gray in 5 fraction and a time frame of 5 to 6 weeks. Then gemcitabine 400 mg per meter square weekly. Upon completion of the surgery and chemoradiotherapy, regardless of sequence, systemic chemotherapy was administered. Gemcitabine 1000 mg per meter square on day 1, 8 and 15 every 4 weekly for 16 weeks. So interim analysis performed after 50% accrual and the study was terminated given the high number of death in the upfront surgery. R0 resection was higher with the neoadjuvant treatment. On intention to treat analysis, 2-year OS was and median OS 2-year OS of 40% versus 26% and median OS of 21 months versus 12 months were better in the neoadjuvant treatment arm. Criticism of this trial include the use of local regional chemoradiation in the neoadjuvant setting, use of single agent chemotherapy upon completion of all local regional therapy, given the existence of more modern multi-agent systemic adjuvant regimen. This trial demonstrated that preoperative therapy improved survival compared to postoperative therapy in patients with borderline resectable pancreatic carcinoma. So preoperative therapy improved survival compared to postoperative therapy in patients with the borderline resectable pancreatic ductal adenocarcinoma. There is one study Alliance A021101. So it is single arm multi-institution phase 1 feasibility study of patients with borderline resectable pancreatic ductal adenocarcinoma who received 4 cycles of modified FOLFIRINOX, that is 85 mg per meter square oxaliplatin, 180 mg per meter square irinotecan, 400 mg per meter square leucovorin and 2400 mg per meter square 5FU every 2 years weekly, followed by 50.4 gray of external beam RT, capecitabine 825 mg per meter square twice daily over 5.5 weeks, 20th fraction prior to pancreatectomy, followed by 2 cycles of a single agent gemcitabine 1000 mg per meter square day 1, 8 and 15 every 4 weekly. Trial was limited to high volume pancreatic surgery centers and radiation plan were centrally reviewed to ensure quality control. Total of 29 patients were registered, of whom 23 were included after the centralized radiographic review and a 22 initial therapy, and a total of 5 patients progressed while on therapy and 6 patients had radiographic response, complete response. The rate of the grade 3 or higher adverse events was 64% and 15 patients underwent pancreatectomy. So 12 patients required vascular resection, 14 patients required R0 resection and 5 had major pathological response, 2 of whom complete response, and median OS was 21 months. This study demonstrated a multi-institutional study in the borderline severe pancreatic ductal adenocarcinoma was feasible within the United States. Also demonstrated the importance of the centralized radiographic review and standard definition of the anatomical resectability. And a common criticism by opponents of the neoadjuvant therapy is the loss of window of resectability, and this trial demonstrated progression is most often distant, arguing the earlier pancreatectomy would not have helped 4 of the 5 patients who progressed. So the group of Massachusetts General Hospital recently published single institution, single arm phase 2 neoadjuvant therapy trial of borderline resectable pancreatic ductal adenocarcinoma. They have given 4 cycles of FOLFIRINOX and followed by CT chemotherapy followed by CT restaging, and if progression, additional 4 cycles of FOLFIRINOX was administered, then CT restaging, then multimodality review will determine the next step, and if there were no vascular involvement Then short course proton on standard proton chemoradiotherapy was administered. So 25 gray 5 fraction of proton or 30 gray 10 fraction of standard proton with capecitabine, that is 825 mg per meter square twice daily. And for patient with a persistent vascular involvement, long course chemoradiotherapy was administered with a dose of 50.4 gray 28 fraction intensity modulator RT. Vascular margin abutting the tumor receiving total of 58.8 gray and capecitabine 825 mg per meter square twice daily, or 5FU 225 mg per meter square per day. And the protocol was amended to reflect the patient treatment protocol as described above, and the initial iteration of the protocol called the 4 pre-op cycles and 4 post-op cycle of FOLFIRINOX, the primary endpoint of R0 resection, secondary endpoint of PFS and OS. Total 50 patients they were enrolled, out of which 48 met the eligibility criteria and 5 patients were treated at protocol amendment. So total 39 patients completed all the pre-operative cycles of chemo. 44 patients proceeded to chemoradiotherapy. Total 32 patients underwent pancreatictomy, and out of which 31 had R0 resection. And median PFS was 14 months. 2-year PFS 43 months. Post-amendment median PFS was 19 months. Median OS 37 months was not reached the post-amendment cohort. 2-year OS 56%. 32 patients who underwent pancreatictomy, median PFS was 48 months. 2-year PFS was 55% and median OS was not reached, and overall OS was 72%. While the margin negative resection rate survival outcome, they are impressive in light of historical outcome. The study is open to criticism given the single arm design and one size fits for all. It is not clear from the result of this study how many cycles of systemic chemo are needed and which regimen is preferable. And it is likely some patients were overtreated by 8 cycles and some treated were undertreated, and some patients have derived more benefit from alternative regimens such as GEM, nab-paclitaxel. Use of short course, long course chemoradiation introduced. Confounding benefit of either is not clear. So Alliance A021501 trial phase 2 RCT compared patients of borderline resectable pancreatic ductal adenocarcinoma treated with the 8 cycle of FOLFIRINOX compared to patients with the 7 cycle of FOLFIRINOX. Now they have given a number 8 versus 7, followed by SBRT 33 through 40 grain 5 fraction, hypofractionated EGRT 25 gray 5 fractions. Patient proceeded to pancreatictomy if no progression was noted and post-operatively given 4 cycle of FOLFOX. And the primary endpoint 18 months of overall, which was compared with the historical control of 50%. The planned interim closure of either arm, which was fewer than 11 months of the first 30 enrolled underwent R0 resection. A total of 155 patients were registered. 126 included after central radiology review, and the radiation arm reached futility and was prematurely closed. Of 66 patients in the modified and FOLFIRINOX, 38 were taken for surgery, 32 underwent pancreatictomy, underwent R0 resection, 20 completed all treatment, and out of 55 patients in the FOLFIRINOX radiotherapy arm, 28 were taken into surgery and 19 underwent pancreatictomy. R0 resection and 10 completed all treatment. 18-month OS 68% with the neoadjuvant and 47% with the neoadjuvant and radio, and with median OS of 31 months versus 17 months. So there are several conclusions withdrawn from this, that FOLFIRINOX improves OS compared to historical control and appears to establish backbone of standard therapy for patients with borderline resectable pancreatic ductal adenocarcinoma. SBRT and hypofractionated IGRT, they do not appear to improve survival and do not appear to have broad role in standard management borderline recipient pancreatic cancer. Although there may be subset of patients who benefit, study raise the question of SBRT could be detrimental in this context. Conventional long course RT not part of the study. And there is pre-panic study. Pre-panic study included both the resectable borderline resectable pancreatic ductal and subset of patients with borderline resectable pre-operative chemoradiotherapy improved OS. So borderline resectable pre-operative chemoradiotherapy improved OS. And aspect 5 of the upfront surgery or neoadjuvant gem cap 2 cycle, FOLFIRINOX 4 cycle or 50.4 capecitabine based chemoradiation. Primary endpoint recruitment R0 R1 resection. Secondary endpoint OS. So 1 year overall survival is improved with the neoadjuvant therapy. Several ongoing studies like pre-panic 2 include patients with both resectable and borderline resectable. Then PANDAS PRODIGE 44 comparing efficacy of neoadjuvant M FOLFIRINOX 4 cycle followed by pancreatectomy to sequential M FOLFIRINOX 4 cycle and 50.4 capecitabine based chemoradiotherapy followed by resection. Post-operative patient will receive gemcitabine or 5-FU chemotherapy. In the primary endpoint R0 resection, secondary endpoint include overall survival, PFS, quality of life, and results of these trials awaited.